Thank you very much, and I think you're absolutely right. It is that middle space, and our next speaker has coined an appropriate phrase to help us through that, the mushy middle. So without further ado, I'd like to introduce Dr. Susan Watt, a professor of social work at McMaster University in Hamilton, Ontario. McMaster also is the university host of the UN University Institute for Water, Environment and Health, and Susan was instrumental in securing the SSHRC Connection grant, so thank you very much for that. Her research is primarily in the healthcare and social policy fields, particularly about the intersection of these policies in practice. Substantively, her work on the Ontario Mothers and Infants Studies, the TOMIS, the Ontario Training Centre in Health Services and Research Policy, and the Transdisciplinary Understanding and Training on Research for Primary Healthcare Tutor, Primary Healthcare, that's the Tutor PHC, have used the experiences of primary care providers and patients as principal study groupings. She's an adjunct professor with us at UNU-INWEH, and her work with us focuses really on water, sanitation, and maternal and child health in East Africa. So thank you very much, Susan. To sit there.
Thank you. And I am a fraud. I know nothing about water and very little about sanitation, beyond what most Canadians know, which is I turn on a tap and expect to get clean, cold water to drink, and I flush my toilet, and if it doesn't work, the next number I call is my local plumber. What I do know a lot about is maternal and child health and how to increase communities' capacity as decision makers. So I work in what I've called the conflicted, mucky middle of policy and practice. I do capacity development, capacity retention, which is one of the larger issues in low and middle income countries. We can train all the people we like if they never turn up back in any of those low and middle income countries. And in maternal health, education, and program evaluation, primarily in Uganda, and primarily with Save the Mothers program. So don't expect me to know anything about water and sanitation, but I come to speak because if you're concerned about maternal and child health, you inevitably have to be concerned about water and sanitation. Let me just set the stage, because if you know as little about maternal and child health as I do about water, you need to know the following. Complications during pregnancy and childbirth are the leading cause of death and disability among women of reproductive age in the developing world. In Uganda, the maternal mortality rate is 430 women per 100,000 deliveries. In Canada, it is 7.8. Every minute, somewhere in the world, a woman dies of the complications of pregnancy. This is the equivalent of 150 jumbo jets crashing every year. So lest you think it's not a problem, because it basically isn't in most of Canada, although there are places where it is. In the rest of the world, it's a huge problem. We approached this problem initially by creating more professionals. You know, we trained a lot of doctors and we trained a lot of nurses, and we said, go out there and cure the world. But our problem definition was hugely misplaced. Women and children, first of all, in most low and middle income countries, just don't count. They're not in census, they don't have birth certificates. When they die, they're buried in a back field. So we don't even have data to know how big some of these problems are. Secondly, they often don't have power. They can't own land, they don't belong to decision-making groups, and if you don't belong there, you don't get your needs met. In Africa, a woman is 250 times more likely to die in pregnancy than in North America. That's not a function of medical technology. That's a function of the fact she goes into pregnancy too early, too unwell, and without access to basic resources. So I, as a maternal and child health researcher, am confronted with the fact that I really need to know what's happening to those things. So the simple problem of maternal and child health isn't nearly as simple as we initially thought it was. It's a complex problem that requires both professional and community-driven solutions, and it is in that mucky middle that perhaps some of it can be resolved. The problem, very simply stated for me, is that women and children are dying of changeable causes. The cause, the deadly delays, the lack of fundamental resources, the lack of systematic prevention and care, stems from fundamental solutions to access to quality water, access to safe sanitation, access to safe and timely transportation, and education. These deadly delays have been noted, studied, evaluated to death. You should pardon the pun. We know what the problem is. What we haven't been able to do is come up with many really good solutions. Let me give you an example of one on-the-ground solution that actually is trying to get the problems moved up the chain of command. This example serendipitously happens to be in Uganda. The minister is very aware of it. But it is a Canadian program, NGO called Save the Mothers, which started in Yemen and now is focused just outside of the capital in Uganda and is associated with a university in Uganda. And it said, okay, we're going to take on the mucky middle. We're going to train people who are out in the field to understand maternal and child health. And then we began to actually ask some questions about evaluating the impact of that, and ultimately said to them, well, how can you do that if you're not training them about water and sanitation? So we have just added a chunk of work on water and sanitation to this program that trains members of parliament, journalists, high school teachers, local counselors, nurses, physicians, but very few of the latter. They've really targeted journalists, policymakers, teachers in public schools to come in and learn about maternal and child health, and in this way to learn about water, now to learn about water and sanitation. And we're helping those teachers and those journalists and that whole crowd of STM grads go forward and really look at how in Uganda we can solve some of these problems, including water and sanitation problems. So it's a ground up example of change. However, one of the nice pieces is that the wife of the president of Uganda is the patron of STM Uganda. So there's a bit of top-down too that happens in a very different kind of way, because Mrs. Museveni has the ear of the president. And it really denotes a shift in attitudes about maternal and child health in a developing country, and makes a very Canadian thing, social determinants of health, for which we are known around the world, the center of doing this kind of intervention. We would argue that both practice and policy are critical, and neither is sufficient. It is only when they are involved in a McMaster phrase called the iterative loop. If you hear that term used, you think McMaster. So we do two things. We see it as an ongoing process of iterative change, and the second thing we do is we train using problem-based learning. So when I take students to a hospital, I put that in quotes, a health center in Uganda, that Canadian dollars have built, and there's no running water and there's no sanitation plan, I'm forced to explain that to students, to explain how could you build a hospital with a labor and deliveries suite, we use that term, a room where women deliver babies that has a mud floor and no supplies and no running water and no sanitation plan. So we do have water and sanitation as a pretty critical part of what we're doing when we're training people. What we've learned is that a lack of awareness of the problem is probably the biggest thing that stands in the way of change. I am always amazed when I talk about operating theaters with no running water and no sanitation plan, that very intelligent, very knowledgeable people look at me and say, are you out of your mind? You can't have an operating room without running water and a sanitation plan. You're saying, come, I'll show you. You can. They're all over the developing world. So education really becomes a critical key for the kind of work I do, at least. Then a lack of understanding of the problem. People say, but we put all kinds of wells in all kinds of places in the world. And you try and explain that they don't keep operating on their own forever. You try and explain the complexity and depth of the problem. Cultural barriers to change are a huge issue. As a social scientist, I know that I can put in a new water treatment plant, and if people don't believe that the water is better, I might just as well save myself millions of dollars because they're not going to use it anyway. There must be support from the top down, and there must be technology, but technology is not the only solution. Action, in fact, happens in the mushy, conflicted middle. Some of it's planned, and some of it's random, but all of it requires both top-down and bottom-up. Serendipity is a not well understood but critical part of development. It's who you happen to meet in the lounge in Nairobi when you're transferring from A to B and the conversation that you have. And it is a huge part of development work. Failure, if we don't succeed at water and sanitation changes, women are going to continue to die, and I would argue that this is no longer acceptable. So I'll leave you with one thought, and that's, I would if I could get to it, that there's huge power in words to change what people know and how people feel about this problem. So join us in changing some of the words. Thank you.